Viral persistence from COVID-19? In a recent interview, the head of the NIH mentioned that they now believe viral persistence is one of the major contributors to long-term COVID-19. Studies are now starting to point to the possibility of viral persistence of SARS-CoV-2. Why is it so controversial when there are several viruses that persist? Viruses that persist. 1. Herpes viruses. These include herpes simplex virus, HSV, which persists in neuronal cells, nerve tissue near the spine for HSV-1 and sacral ganglia for HSV-2. Varicella-zoster virus, VZV. It persists in the dorsal root ganglia and can reactivate to cause shingles. Epstein-Barr virus, EBV. It can persist in B cells and has the potential to reactivate under certain immunocompromised conditions. Cytomegalovirus, CMV. Typically persists within the salivary glands and other tissues. 2. Human immunodeficiency virus, HIV. Persists in various cellular reservoirs, including CD4+ T cells, macrophages, and potentially CNS tissue. 3. Hepatitis B and C viruses, HBV and HCV. These viruses primarily persist in liver cells. Chronic infection can lead to liver cirrhosis or cancer. 4. Papillomaviruses persist in the skin and mucosal tissues, potentially leading to the development of warts and other lesions and, in some cases, malignancies like cervical cancer. 5. JC virus generally persists in the kidneys but can become reactivated and progress to the brain, causing progressive multifocal leukoencephalopathy, PML, in immunocompromised individuals. So why do some viruses persist? It starts with immune-privileged sites. Immune-privileged sites are areas in the body where the immune response is either partially or completely suppressed, making them less accessible to the normal immune surveillance mechanisms. This unique attribute is designed to protect delicate tissues from potential damage that could occur from a typical inflammatory immune response. However, these sites can also provide a sanctuary for viruses to persist, sometimes for the lifetime of the host. Immune-privileged sites. 1. The central nervous system, CNS. This includes the brain and spinal cord, which are protected by the blood-brain barrier. 2. The eyes, specifically the subretinal space and the anterior chamber, which limits immune cell access. 3. The testes and ovaries. These organs limit immune responses to protect developing reproductive cells. 4. The placenta acts to protect the fetus from maternal immune responses during pregnancy. 5. The bone marrow is an important site for the generation of immune cells, but it is also regulated to prevent immune attack. 6. The cochlea, the part of the inner ear involved in hearing, protected to prevent damage that could result in hearing loss. 7. Pregnancy decidua interface, the lining of the uterus during pregnancy, similar to the placenta. It is crucial for protecting the fetus. Treatments. Many persistent viruses are difficult to treat. One issue is that medications have a hard time getting to the locations, and when they do, they're not as effective. The difficulty in treating immune-privileged sites with drugs stems from several intrinsic and functional characteristics of these areas. Here are the main reasons why these sites are challenging to target with therapeutic interventions. 1. Physical barriers. Many immune-privileged sites are protected by physical barriers that restrict the entry of substances from the bloodstream. For example, the blood-brain barrier, BBB, protects the CNS by tightly regulating the passage of molecules between the bloodstream and the brain tissue. This barrier is highly selective and prevents many drugs from reaching therapeutic concentrations within the CNS. Similarly, the blood-testis and blood-retinal barriers protect the testes and eyes, respectively, limiting drug access. 2. Reduced immune surveillance. The immune system itself is either suppressed or partially inactive in these areas to prevent damage to sensitive tissues. While this suppression protects tissues from autoimmune reactions and inflammation, it also means that the natural immune mechanisms that help clear infections are less effective. This makes it challenging to leverage the usual immune-mediated clearance of pathogens, including viruses, in these areas. 3. Specialized microenvironment. Immune-privileged sites often have a unique microenvironment that supports the specific function of the tissue, such as vision in the eye or sperm production in the testes. These specialized conditions can alter how drugs are metabolized or how effective they are within these tissues. 4. Lack of lymphatic drainage. Some immune-privileged sites, like the CNS, have limited or no direct lymphatic drainage, which affects the ability of immune cells to enter and exit these regions. This isolation not only impedes the natural immune response, but also complicates the delivery and effectiveness of immunotherapeutic agents. 5. Drug toxicity and side effects. The tissues in immune-privileged sites are often highly delicate and susceptible to damage. Consequently, there is a higher risk of severe side effects if drugs are administered in doses sufficient to cross protective barriers. This necessitates a careful balance between drug efficacy and toxicity, often limiting the use of potent drugs that could damage sensitive tissues. 6. Specificity of drug targeting. Designing drugs that can specifically target these areas without affecting other parts of the body is a significant challenge. This requires advanced delivery systems or modification of drugs to ensure they can cross protective barriers and act only within the desired site. 7. Ethical and safety considerations. Due to the critical functions of many immune-privileged sites, like vision, cognition, and reproduction, there are stringent safety and ethical considerations in conducting research and trials for treatments targeting these areas. This can slow the development and approval of new therapeutic approaches. Because of these challenges, developing effective antivirals for immune-privileged sites often requires strategies such as designing drugs with higher penetration abilities, using nanotechnology for targeted delivery, or employing local rather than systemic drug administration. Each approach must be tailored to the specific characteristics and needs of the targeted immune-privileged site. What are some of the studies? The first result, 1, discusses how scientists have found SARS-CoV-2 proteins persisting in the blood of some long COVID patients, even months after initial infection. A study at Brigham and Women's Hospital found viral proteins in 24 out of 37 long COVID patients, while no viral trace could be detected in 26 people who had recovered from COVID-19 at least 1 month earlier. 1. This suggests viral persistence may be sustaining long COVID symptoms. The second result, 2, reports on UCSF research that detected COVID-19 viral RNA and antigens persisting in blood and tissue samples for over a year and up to 2 years after initial infection. The researchers found these viral fragments were more common in people who were sicker with COVID-19 initially. The fourth result, 4, describes a large community study in the UK that found people with persistent SARS-CoV-2 virus in their nose or throat at least 30 days after infection were 50% more likely to report long COVID symptoms at 12 weeks or beyond. Additionally, the third result, 03, notes that the preprint response to COVID-19 has been much larger than for other recent viral outbreaks, with over 10,000 COVID-19 preprints posted in the first 10 months of the pandemic. 3. This indicates the scientific community has rapidly shared new research on COVID-19 viral persistence through preprints. In summary, multiple new studies, including some published as preprints, point to the persistence of SARS-CoV-2 virus and viral components in the body for extended periods after initial infection, which may be linked to the development of long COVID.